So good morning, everyone. Again, a very nice Monday, everyone. Monday morning, we are already there to learn something, which is very, very important. In day-to-day practice, you will find many, many patients that those are coming. Either patients are angry or caregivers are angry, especially when they see that the loved one is either dying or they feel that it's not taken care properly. So how to handle those patients, those who are angry, or the relatives, those who are distressed, how to take care of those patients. For this, I think we have two very, very intelligent, I think coordinator. I know Puneet very well, that he is going to coordinate this seminar, who is our first MD palliative medicine student and working as a consultant in Gangaram Hospital. And the speaker is Snigdha. Snigdha is probably their DNB student, first year DNB student, or maybe uh, first year DNB student in palliative medicine. So Puneet and Snigdha, all the best, and very important topic. And I know that you will do well. Let's see that what exactly you have to say when a patient is or relatives are in angry or in distress. Thank you very much.
Good morning, everyone. I'm Dr. Snigdha. I'm first year resident at Gangaram Hospital in the Department of Palliative Medicine. Today, I'll be talking about how to approach an angry patient or a caregiver in a palliative care setting. An overview to today's lecture. We'll start by talking about definition and how anger is a part of palliative care on a day-to-day basis. We'll discuss the Kubler-Ross grief cycle, some statistics on anger in palliative patients, an example of a case, what are the risk factors that lead to an angry patient, what are different causes, what kind of tools and techniques that we have to deal with such angry patients, what are de-escalation techniques, how we can use assertive communication to approach such patients, and how we're gonna eventually end up approaching the case that we'll discuss in the beginning. What is a spiritual anger and how we can prevent such cases, and little note on aggression as well. Starting by definition, according to the American Psychological Association, anger is an emotion, much like any other emotion, characterized by antagonism towards someone or something that you feel has deliberately done you wrong. It can be a good thing, it can motivate you to find solutions, it can help you express negative emotions. But in palliative patients, anger can invariably a form of tension release, a coping mechanism, which in a way comes out, which disguises as fear and anxiety. Fear and anxiety disguises themselves as anger. Then Dr. Elizabeth Kubler-Ross in 19th century gave 5 stages of grief. This can apply to both patient and relative. After an initial phase of denial towards a disease, they go into the stage of anger. The anger can be directed at medical professionals. They can blame you for inadequately providing treatment, or they can blame the family members for contributing to risk or not being sufficiently supportive towards him, or they can be angry at higher power for the injustice of diagnosis. They can have short temper outburst or loss of patience. As healthcare providers, we need to understand that anger is a natural response and it is in no way a form of hurtful accusation to anyone. This is a small study of 230 patients, which was conducted in year 2015, where patients who came to palliative OPD were assessed on basis of the kind of emotion that they have expressed during that consultation. It was found that anger was present in 27% of conversations, along with fear and sadness. They also concluded that when fear and anger are expressed in a conversation, they were most commonly expressed at the beginning of the conversation. There's a small case discussion. You are the palliative resident on call. You receive a call from ward about an angry relative who is shouting at staff regarding high cost of treatment. Upon, upon further inquiring from the staff and case file, you came to know that the patient is suffering from advanced cervical cancer and patient is growing sick by the day. She has been treated aggressively with chemotherapy and radiotherapy and is being in the hospital for the last 45 days. So what do you think are the issues here that are making relatives angry? Most probably the patient is not angry at the healthcare provider per se. They are angry at the fact that even after spending a lot of energy, time, and resources towards taking care of the patient, they are going to eventually lose the patient. It is the sadness that is manifesting as anger. And how we will approach this scenario, we'll discuss that later. So, what can be the risk factors that can lead to an angry patient? There can be few medical causes. A patient who is hypoglycemic, who has not slept well, an Alzheimer's patient, a hyperthyroid patient who's uh, going through premenstrual dysmorphic disorder, patients with temporal lobe epilepsy, traumatic brain injury, or acutely delirious can have anger outburst. Patients who have substance abuse history, patient who are alcohol intoxicated or on methamphetamines, patient who have mania or depression underlying a personality disorder, undergoing PTSD, or in general undergoing grief cycle can present as angry. We'll discuss causes that can lead to angry patient based on three criteria. First one would be what are the physician related factors, next would be what are the patient related factors, and third would be what are system related factors. Starting off with physician related factors, the most common one would be misdiagnosis or medical error. So how we can deal with it is start off by explaining what happened and tell them stepwise manner how you're going to rectify this and how you're going to prevent this happening in the future. Next would be poor bedside manner. We can we can train physicians on how to show empathy and being present during the being mentally and emotionally present during rounds or whenever you're meeting the patient or the relatives. So one important part of palliative medicine is learning how to give bad news. We have to be thorough with Spike's protocol and learn how to break bad news. Then poor communication skills on poor communication skills of the physician can again cause patient or relatives to get angry. You need to be you need to be you need to make the relatives and patient part of your decision making. You need to provide your rationale for procedures and medications or why a certain medication is not being prescribed. Keep the patient and relatives up to date on test results. What are the next steps in the management and how they can take care of the patient better. And another reason could be not acknowledging or exploring a patient's beliefs. And we need to be appropriately trained in cultural awareness and what is deemed right in a particular culture, that in the area that you're practicing is very important. Next is system related factors that can lead to an angry patient. First is high cost of care. So in the beginning of the consultation, we should make sure to inquire about the patient's financial concerns. We can help them reach out to appropriate resources, social workers, and make whatever attempts we can on our basis to either by not frequently repeating tests or not ordering high-end medicines in order to help such patients. And we need to train physicians on emotional intelligence so that we are equally capable of dealing with such angry patients. Then we need to as physicians, we should not be brained out and not let our physical burnout to impact our communication. We need to improve our own emotional wellness, and in order to provide emotional support to the patient. Um, we need to have a coordinated care so that systemic inefficiencies are minimized to whatever extent that is possible. And before starting a patient on a particular treatment, they need to be made aware what kind of side effects they are to expect and how much cure or symptom relief they should expect after the completion of treatment. So what can be patient-related factors that can lead to an angry patient? Patient who is in chronic pain will invariably end up being angry at the healthcare provider for not being able to take care of them. So whenever you find a patient angry, start off by taking care of the pain. You need to consider the psychological aspect, the social aspect, and the biological aspect of the pain. If the patient is a substance abuser and that is causing him to get angry, you can offer him cognitive behavioral therapy and eventually lead him to a path of drug abstinence and treatment. If there is an underlying illness going on, an acute delirium or a depression underlying, we can start off by uh, sending for a psych consult or treating any underlying hyperthyroidism. In case the patient feels that he or she is not being listened to, you need to start having frequent conversations with him about um, how his symptoms is affecting his lifestyle, what is triggering him to get angry. And one of the ways that you can help patient talk more about it is by paraphrasing or reflective listening. For example, when patient says that this is how I'm feeling, I'm not being looked after, blah, something like that, then you have to say that, oh, it seems like you feel you're not being taken care properly. Let's see what we can do about it. So that way, opening a conversation by acknowledging what he has said to you will will make him feel that you are listening to the conversation. There can be cultural or religious misunderstandings. Not, for example, if you are not um, accompanied by a chaperone while examining a female patient, or you're not. Uh, so this one time, I asked one patient about what are their eating habits, like if they are vegetarian or non-vegetarian. They got offended for me asking that, are they non-vegetarian? So make sure you know what kind of background patients that you receive in a clinic, and being uh, empathetic towards their cultural preferences. Then psychosocial issues in a patient's life can lead him to get angry frequently. So we need to inquire about what stresses he has in his life, and frequent conversations with him with and discussing what are his experiences with the disease and empathizing with him can some to some extent help him deal with such issues. Then when you tell a patient about a serious diagnosis, a terminal disease, it is very difficult for him to uh, grasp with the reality of such diagnosis. You can help this patient process grief by adding him to some support groups where he can talk about it with other patients who are going through similar illness. Then the one of the most important cause of anger in patients is transference, where an anger towards something is manifest as anger towards you. The patient might be angry at some other clinician for making a wrong diagnosis or delaying the treatment. And then he starts thinking that everyone in the medical profession is like that and everybody else is responsible for how his disease has progressed. So in order to take care of that, you need to explore the source of patient's anger, identify what triggers him, and help the patient express his feelings by a conflict mediation technique. So, how are we going to approach an angry patient and a caregiver? The most important factor is pain. When a patient appears to be angry, the presence of untreated or undertreated pain must be considered and rectified as a matter of urgency. Once you once you treat the pain part of the patient, anger is going to vanish along with it. So, what are different de-escalation techniques that we can use in an angry patient? First, start off by acknowledging that a patient is angry. Acknowledge that he is frustrated and that he feels that he has been wronged. Now, after acknowledging, shift the discussion focus from the anger towards how you can solve the problem that he has now. Start off by telling him that you and I both are working towards a big picture, that is how to keep your life comfortable, how to how to um, make your symptoms go away, and you can start by making way to small concessions. For example, how about you start eating more protein in your diet, and at the same time we'll add some protein supplements to your diet, so that way your albumin levels can go up. So a little effort from your side, a little effort from their side can come off as, you know, that both you and the patient's relatives are working towards the same big picture. And you can monitor the patient acutely, monitor their progress, and whenever it feels like the patient's relatives are accusing you that you're not paying attention to them, make sure that you have read the patient's file correctly and you know all the facts about the patient's disease before approaching them. And you need to make sure that you're not insisting on having the last word or thinking about how to win over this argument. And you can also have a staff member accompany you or the patient's relative when they are uh, in a having an anger outburst. So, what is Spike's protocol? Spike's protocol is a method on how you can break bad news to the patient. So, for that, we can start off by setting. Setting stands for you have to make you have to invite the patient and the relatives to a seating area where there is privacy and where they can express themselves, and then start the conversation by perception. Perception here means invite the family members on what they think about the disease, how much they want to know about the disease. Then and then knowledge. Knowledge is start by discussing what the reports you have received and what that the notes, and uh, assess what emotions they are feeling, give them time to respond, answer their questions, and then summarize in the end how and what are your plans moving forward with the treatment plan and how they want their treatment plan to be. Making sure that you break a bad news on basis of this protocol will reduce the anger outburst of patient later on in the disease. So we have this toolkit that is called the assertiveness toolkit. With the help of this, uh, we can approach the patient. We can approach a patient who is angry at you. We have to make sure that we have good eye contact and make sure you appear as interested and sincere. Your body posture should be friendly and inviting, and you should not get intimidated because of the angry patients or the crowd that you're being faced with. You need to judge what is the best time to respond for maximum impact. You have to talk in a calm and composing tone. Your gestures should add emphasis on what you're trying to say. We have 6 assertive communication techniques. The first one is statement. So, for example, a patient says that nobody has come to see my patient since morning and he has been in pain. So, when approaching such angry patient, you have to start saying that I have personally came down to see the patient and ordered an analgesic. You might have not been there but when I came to bedside. But the point here is that you have to personally get involved and say that you have to use the word I have been involved in this. I have done this. I have asked the staff to provide the medication, and say that how you have been sincere about taking care of the patient. Then second is by repeating what the patient is trying to say and paraphrase that, oh, I understand that you're angry about this. Then third is fogging. Fogging here means being silent for answering difficult questions. This helps us receive criticism and without getting anxious or defensive. The next is negative inquiry. So, for example, if a patient has been in pain, so you can ask him, are you sure you have been taking the medicines on time that we have prescribed you? That way you can be sure of patient's compliance and whether his anger is because of the pain or because of the um, non-compliance. Then next is workable compromise. Uh, what I what example I gave earlier for protein is like where you can ask patient to contribute and then little bit contribution from your side. Both can work towards it. That way, patient will feel that you are, but in fact, taking care of him. So some facts to remember: you need to recognize that attack by the patient are part of grief process and not personal need to differentiate between appropriate and displaced anger. What displaced anger here is whether a patient is actually angry about uh, something that has been done wrong to him, or is it just his normal grief process or how things have turned out for him that is making him angry. Recognize the difference between past and current anger. You need to remember the goal, that is to comfort the patient and not to engage in an argument. And you don't have to become defensive. This is not a fight against you or for you. Acknowledge the feelings of the patient and the family. You need to give the patient and the family control by having them make a choice about something. We need to understand that such patients come at the most vulnerable point in their life to you to get palliative care, and they think that they have absolutely no control over the disease or how much time they are left with the patient. So giving them small choices to make, like how about you start having 3 meals a day, whatever time you choose, either 2 p.m. or 12 p.m. Making them make such small choices can give them control over their own time. If possible, you can decrease the stimulus in the patient's room by decreasing TV volume or bright lights. You have to always speak kindly and directly to the patient. You have to listen attentively, and you have to use a calming tone and volume of voice with the patient. And to the questions where you have no answer, you can use silence. You don't necessarily have to answer each and every question. So while dealing with a palliative patient, you always have to choose empathy over sympathy. You need to put yourself in their shoes and understand that what they're going through is a normal grieving process. But also at the same time, you need to avoid being over compassionate or being too emotional, because that can come off as that can come off as you being a weak person or an inexperienced doctor. There's a small technique or mnemonic that you can use when approaching an angry patient. It's called bathe technique. B stands for a background. We have to actively listen to understand the situation, also being actively aware of the patient's disease and progress so far. You have to acknowledge and validate the emotion that they're having. You have to ask what is troubling them, what scares them, and then how they are handling the dying, and are they making concrete plans about their finances, their family, and then response with empathy, feel make them feel understood, less abandoned and alone. So the case we discussed earlier. So how are we going to approach that case? So first off, we make sure that you know all the facts, read the file beforehand, and then approach the patient and the relative, accompanying with the staff who is actively seeing him all along. Then start off by introducing yourself. Tell them that you are here to address their problems. Then invite them to a private seating area where you can discuss the matters. Uh, Anger is very communicable. So if a patient is angry at and around other patients' relatives, they all will invariably think that you are incompetent. So make sure you have asked the patient and the relatives to come and sit in a private area where you can discuss. Then ensure that you and other patients are safe at all times. You can ask the security personnel to accompany you as well in case you think the patient is going to get violent. Then ask the patient what issues they have, let them vent, listen actively and sincerely. Then once the patient is done speaking, sympathize for how they are feeling and ensure you will help every step of the way. Then explain a stepwise strategy. In the case we discussed earlier, the concerns of the patient's relatives were the high cost of treatment. So you can explain to him how you're gonna help him cut on the cost by ordering less amount of investigation, by stepping down a category of their beds to a sharing room, or you can prescribe them medicines that are easily available or generic medicines, etc. And you can tell them how they can reach you in case they need further assistance. Answer all their questions and make sure they understand and have all their concerns answered. So there's another kind of anger that can be called as spiritual anger, where the person tries to pick a fight with God, or patient is in spiritual pain. So spiritual pain affects who are spiritual, religious, or non-religious. A person does not have to be actively involved in religious activities to go through spiritual pain. So it includes varying degree of discomfort or suffering in one's inner being or spirit. It can be triggered by radical change, physical pain, or shortness of life for oneself or others. And such patients ask questions on meaning of life, or why there is pain and suffering, why am I here, why God allowed this to happen to me. So how can we help those who are angry at God? You have to start by affirming honesty. You have to tell them that you do not have answers to the whys, but you can help them find their own way to spirituality. In no way your answers should include your own personal beliefs. You should allow patient to find their own answers to these questions. Arrange a meet with a church pastor or a hospice chaplain or a guru if the patient wishes to meet them. So we can go either way of this chart while managing a patient with anger. Either we can choose an effective approach, start by acknowledging anger, identify the focus of the anger, then legitimize it, then encourage the expression of anger, and solve whatever problems they have. Or had we not dealt it properly, we could have dismissed the anger, reviewed the focus, and defended the action of ours and colleagues. And that way, patient could have ended up in an anger spiral, which could have led to aggression. So, according to a study by IMA, it is found out that 60% of the doctors are stressed over the fact that patients and relatives become aggressive during a consultation, and 57% of such physicians have thought of hiring security because of the same reasons. This is a picture of an orthopedician doctor who was hurt badly because of an assault upon him by the relatives of a patient who had suffered a head injury in year 2017. He was a surgery resident who had to lose vision in one of his eyes because of that assault. On the left, you can see the chart where violence against doctors leading to the number of strikes in hospital have risen since year 2014. So we need to make sure that we are equipped with techniques on how to deal with anger in patients. Otherwise, that anger can very easily lead to aggression and physical assault on medical staff. This is a checklist which is being used by Canadian Medical Council to assess any aggression incident in patients 24 hours prior. So based on the patient's previous history of uncooperativeness, verbal abuse, hostility, threats, or assaultive behavior, the patient is given score on the basis of that and classified into low level of risk, moderate level of risk, or high level of risk of aggression. And based on that, the medical staff and security personnel are instructed on how to deal with such case. The take-home point, it is also important to realize that sometimes there isn't an answer. Even though you have done all the things right, sometimes patient may feel emotional and it may have nothing to do with you and everything to do with the situation they're in. You recognize that you may not necessarily be able to change that. Keep security close, always ensure your and other patients' safety. Empathy is your best tool in such situations, and practice makes a man perfect. Remaining calm and faced with patients or families expressing anger is an acquired skill that develops over time and exposure to such situations. Thank you.
Wonderful, Snigdha. As a
Thank
first
you.
year MD student, so well you have presented. Puneet, please go ahead with the discussion and take up any question if they have, or any comments from any senior person, how they are handling anger people.
Very good morning, ma'am. Hello.
Yes, good morning. Go ahead.
Good morning, ma'am. Ma'am, the lecture was prepared by Snigdha, and I think she has just done justice to the lecture. Like, I would just like to add upon is that whenever we will all find these patients in our day-to-day life. So whenever we are approaching these patients, we should have a good communication skill. That is the answer. First of all, you should not try to argue or fight against that anger. You should acknowledge the anger. You should know that that is a valid point. That is why the patient or the caregiver is angry. So you should identify the anger. What are the trigger points? There are many causes, as Snigdha had explained. One of the cause I think which she had missed out also was collusion, which is an important part. So all these causes has to be taken care of. And then after these causes are identified, then you need to sit down and communicate properly that what you can do to reduce the anger or find the solutions. And then you need to communicate empathetically. So basically, it is all about communication, and this will not come in just 1 or 2 days. This takes practice. Once you start talking to your patients and caregivers, you will know how will you communicate. And once you know the trigger points, you will be acting in that way. So I would also ask other faculty members who are here and ma'am, that if we have left out any points, could you please touch upon those?
So, Puneet, I can see Jilly Byrne has joined today. So, Jilly, do you want to say something on this lecture? See, this is a team of a big corporate hospital, and the way they have tried to understand that angry patient has to be approached like this. So, I think this has to be congratulated that they are doing really well. So, Jilly, would you like to say something? Otherwise, I can see Dr. Jennifer. Dr. Jennifer.
Would you like me to say anything?
Yes, Jilly, go ahead, please.
Namaste, everybody. Lovely to be here, and very well done. Very, very well done. Thank you. I think I'm very sorry I missed the first couple of minutes. I think very often the really important thing is to, and I admire all your techniques, but the whole listening thing is really important. And the other issue is the truth, going back to the very beginning of at the point of diagnosis. Because I think, unfortunately, what's happening as I see it is that doctors are having to deal with the anger of patients and relatives who have not been communicated well with right from the very beginning. So I think what the really important thing is to think about is how we communicate from the very, very first interaction with the patient, so that we get their trust from the beginning. And many, many patients will be coming, particularly in the palliative care situation, where they've probably or may not have been told the truth, where they've spent all their money and they're afraid. Very often people are absolutely terrified, and this is what leads to anger and us not listening. And I think rather than sometimes us telling them or going through an approach, I think we just have to say, I'd like to hear what your feeling is, and allow them to ventilate right from the very word go, right from the word go, and not be defensive. But I think your presentation was absolutely excellent. But I think, sadly, in the case of many palliative care physicians, they are having to deal with perhaps a lot of maybe medical or nursing practice earlier on that has caused the patients to become angry because they haven't been told the truth, because they've been lied to, and then it's very, very, very difficult for them to overcome that anger. So yes, good communication, absolutely vital. And I know that you know how important I think it is about the whole issue about sitting and listening is really, really important. But thank you. I thought you did really, really well. Excellent, excellent presentation. Well done. Well done.
Thank you, Jilly. Thank you, Jilly. The people, those who maybe they are all youngsters and they must not be knowing, I just want to introduce Jilly is a first palliative care nurse who came to our country in way back in 90s, 80s and started palliative care movement with Dr. Robert Rycross. So they are the first people, those who came to the country. And thank you very much, Jilly. Now palliative care has grown like anything in this country. It's going systematically in community, in district hospitals, in corporate hospitals, in big institutions. And thank you for a great contribution for this country. So now I would like to ask Dr. Say a few words by Dr. Mohan is there and Dr. Jennifer. Would you like to comment, Dr. Mohan and Dr. Jennifer? Hello. Yes, please. Hello. Hi, Jilly. How are you? It's good to see you. And good, you are attending our classes. I'm so happy. Today I saw your name, so I just thought that you were the torchbearer of the starting palliative care movement in this country. So you should be introduced. This is a young generation who is going to take the lead. Those are. I can't hear, Jilly. You are muted.
I can tell you, I met Dr. Puneet at your wonderful conference in Delhi, during the Delhi conference. And he will know that Jilly Byrne is no saint. And that I was very angry, and he was absolutely, I was angry about something. I think I was worried it was going to be late getting to the airport. And he accompanied me to the airport, and he was absolutely wonderful. Wonderful. And I think he was just a student then. And I think at that point I encouraged him to come into palliative care. So I'm Really delighted to see Dr. Puneet there today, and it was as a result of your great conference that you know all these things started and happened. So it's great to be with you all. It's truly really great. And I know from my own feelings of anger at that time, which was not to do with anybody, I think it was to do with the Delhi traffic and anxiety. I was anxious about missing the flight. That when people are anxious, they just blow up. I do. As I said, I'm no saint at all. You know, I'm a human being, and when I have my own anxieties, I'm afraid I'm not all sweetness and light. My anxiety comes through in the tone of my voice, and I'm worried. And Dr. Puneet was absolutely amazing. So, you know, you've got a really good teacher there, and I'm just thrilled to see that he's come into palliative care. I just think it's marvelous. So that's all that I really wanted to say. But I think what you're doing in this wonderful presentation was fantastic, honestly.
Can I say something?
Thank you, Julie. Yes, go, Doctor. Yeah, please go ahead.
Yes, I think it was a super presentation. You know, very well. You know, slides and everything was so good. And I like to take the credit of bringing Julie and Puneet together because they had the session in Gangaram Hospital, which was a thing that I could arrange. And Julie has mentioned a lot of things which are all part of, you know, developing this, building this relationship of trust right from the word go. You know, and when you do that, you know, there is no anger because they trust you. So that's what I want to say. Thank you.
Thank you. Thank you. Absolutely right, Stan. Thank you.
Thank you, Dr. Sterle. Thank you very much. And thank you, Julie, for bringing 2018 memories of the conference and your experience. Thank you very much. Anyone wants to say anything? Please go ahead. Open your mic on this topic, your experience, something which you have felt. Dr. Meenakshi, would you like to say something? Dr. Nandini is also there. Dr. Meenakshi first and Dr. Nandini.
Yes, ma'am. Good morning, ma'am. Ma'am, just of course want to congratulate Dr. Snigdha and Dr. Puneet for this excellent lecture, and just wanted to highlight one or two points. One is paying attention to the body posture. If there is a sign of aggression among the caregivers or the patient, sit them down. I mean, no matter we are all working in resource constrained settings. Sometimes it's in the corridor of the ward. Take them away from from points of conflict in the corridor or the ward bedside. Make them sit down, and you also sit down, because if you're towering above them, it's just going to fuel the emotions further. That's one. Second is also if you are feeling overwhelmed with work, or you're unable to handle, call for help, especially the junior staff. Sometimes they have they have to attend other calls. They have received 3 other calls from the ward demanding their attention, and this patient is being angry and not listening to them or whatever. Always ask for help. I mean, and if it's sometimes it's not our day, you can just say that this is something I don't handle today, and I can call for help, call my other colleague, call your counselor, who can take the edge off this situation for the time being. And other points already have been emphasized by all the seniors who have already commented. Thank you.
Thank you, Meenakshi. Thank you very much. Dr. Nandini, would you like to add?
Sure, sure, Krishna. Thank you.
Go ahead.
Yes, I very much like to appreciate all the comments, especially the the communication skills, sitting them down, and all the other points mentioned, and how Jilly brought in the personal aspects of how anxiety can project and the uncertainty can project as anger. So the presenter definitely mentioned about naming the emotion and validating it. But I think that has to be a bit emphasized in the sense that I can see that you're a little upset and angry right now. Can we sit down and talk about it? And then anyone in your position would have felt the same way. That's a good way of validating, because that is what the whole shouting part of it is basically because they feel they are not being heard. And as soon as we explain, I mean, we convey that, look, you have communicated your anger, and I can also see that, you are, you need some more information on certain aspects. So their uncertainties acknowledged. And if they are looking anxious, that part. So actually naming those emotion, actually, I mean, I use a lot of this tool called NURSE, NURSE, for empathetic. That is how I, also teach everyone whom I come across, naming the emotion, expressing understanding, respecting, validating that particular emotion, and then express the support, and only then start exploring, because all these steps are so important. So when we make them sit down, it is with all this, it is not simply, okay, let us sit down and talk. Only when they feel somebody is now going to hear them or listen to them, it looks like this person is beginning to understand what they are going through, then they will sit and talk. And also, if there is a crowd, sometimes it happens, you must say that, who would like to come in and sit and talk more about it, because the crowd is always in a crowd kind of frenzy. So it is always good to detach a few, spokesperson from the crowd into the cabin and then have a conversation. So that is the few things I wanted to add. Thank you.
Thank you, Nandini. Thank you very much. And I think they all are important points for all our youngsters. Any student or anyone wants to share their experience, because we have time today. Otherwise, I would request Puneet to summarize, and then we will
I
stop.
want to say something.
Yeah, Hanife, please say something. Definitely. Go ahead.
Well, as Jilly said, trust is very important. But one thing that we must pay attention to is to keep everyone, as best as we can, on the same page who are dealing with the patient. When they get different information, different from different people who are coming and going into their journey, they get more confused and the anger builds. So keeping the caregivers, nurses, doctors, everybody on the same page and giving the same information is sometimes very helpful, so that the anger does not build up as severely. That's all.
Thank you, Hanife. Thank you. So today Hanife is also there. So Delhi has started and Hanife is doing right now. Everywhere she's going and teaching the same thing, same empathy, how to communicate, how to take care of the patient, and teaching palliative care in different part of the country. And recently, yesterday only, they were at Silchar and they did fantastic job at Silchar. I think, thank you very much, Hanife. Thank you very much for your commitments, for everything. So,
Thank you.
anyone, any youngsters, those who wants to say something, please go ahead. Otherwise, we will stop. So, Puneet, would you like to summarize?
Yes, ma'am. First of all, thank you everyone for your suggestions and appreciation. So I would just like to summarize by telling all the youngsters here that all patients are different. All the approach must be individualized. So what we need to do is communicate properly. As ma'am told, that communication is the key. So communicate properly, identify the trigger points, acknowledge the emotions, use the spikes protocol daily, use the nurse protocol as Anandini ma'am told. That is very important tool. Use it daily, acknowledge, and the key point is sit down and listen. As Jili ma'am told, that listening should be more in our conversation rather than just speaking out. So active listening should be there. We will be identifying those trigger points, because the more they speak, you'll be getting more clues and triggers that why they are angry. And then you communicate properly, make good plans, and then the patient will be out of anger, and you will do justice to make him as comfortable as possible.
Thank you, Puneet. So I think today's seminar was fantastic. Everyone said such an important point, and you will get every day one or two angry patient or agitated patient, distressed patient. approach is going to be different because patients are different, their reasons are different, but your attitude should be the same. And your attitude, acknowledging the emotions, listening skills, making them understand, giving them same information to all the relatives, same information. There should not be any dispute between the giving information to one person to another person. And if, as Meenakshi said, if you are tired and if you think that whole night I was having duty and early morning at 4 o'clock a distressed or angry patient has come and relatives are very angry, and if you are tired and if you think that it is not going to be helpful if I will speak to the patient, please take your help from your seniors. I think all these points are very, very important. So always remember, every patient is going to be different, but your attitude, and every day you will learn. So every patient is going to teach you something, and every day you have to communicate in a manner which is going to be, although the principles will remain same, but your the information, communication, and is going to be different on case-to-case basis. So communication is a broad term, but your attitude, your acknowledging the emotions, listening skills, and taking help if you are not very sure that you are in under. You yourself should not be stressed because you have to be very, very calm. And all these points are very, very important. Thank you very much, Puneet, and thank you, Snigdha. I'm so happy that first year MD palliative medicine student, they speak so well on such a tough topic. If we would have given on pain management or spinal cord compression, I think she could have done or simply, but on communication and talking to an angry patient, and I think this was fantastic. I was looking for Dr. Santosh, but I think he has not joined today. So anyway, but thank you, Jilly, thank you, Hanife, Meenakshi, Dr. Nandini, Dr. Stanley, for giving your comments, and everyone for listening carefully or patiently. And thank you, Puneet, and thank you, Snigdha. Thank you, Archana, and thank you, Nisha, for making this happen and coordinating so well all over the country. Thank you very much. We will see you next week before 6:30. Next week, Monday before 6:30. Probably next 3 Mondays, I will not be there, but I will make sure that who is going to be there to coordinate. Thank you very much.